Welcome back, medical coders and health information management pros, to today's Focused Explainer. Today, we're doing something a little different. We are bridging that critical gap between what's actually happening in the patient's gut, the clinical gastrointestinal pathology, and the exact ICD-10-CM coding for it. Because, in our line of work, a code isn't just some random string of letters and numbers. No way. It's the ultimate distillation of a patient's entire clinical story. To code it right, you've got to really understand what's physically happening inside the body. So for this explainer, we're going to put on two different hats. First, we'll be the clinical pathologist, getting a look at the disease itself. Then we seamlessly switch over to our master coder mindset to translate that physical reality directly into the chart. All right, let's jump right in. Here is our roadmap for today. We're traveling down the GI tract and hitting the accessory organs. We'll kick things off with alcoholic hepatitis, move on over to alcoholic pancreatitis, loop back to the liver for cirrhosis, and then finish up in the stomach to decode alcoholic gastritis. Okay, section 1. Let's start our journey with alcoholic hepatitis and its absolute most defining clinical complication, ascites. Channeling our inner clinical pathologist for a second, what does alcoholic hepatitis actually do to a patient? We're not talking about a mild tummy ache here. This is rapid, severe inflammation of the liver, totally brought on by long-term alcohol use. When you're scanning a physician's history and physical exam notes, what should you be picturing? Well, you'll see documentation of profound fatigue, acute abdominal pain, nausea, loss of appetite, the whole shebang. But the visual diagnostic indicators, those are the real giveaways. You're looking for acute jaundice, that severe yellowing of the skin and eyes, and dark urine. That dark urine is a huge red flag because it tells us bilirubin is building up, simply because the inflamed liver can't process it anymore. Now, if you need a reminder of why your accuracy matters, check this out. Up to 40%. That's the 6-month mortality rate for severe cases of alcoholic hepatitis. 40%. It's often sudden, it's highly life-threatening, and it absolutely requires immediate alcohol abstinence to save the patient. So as coders, when we see alcoholic hepatitis in the chart, we've got to treat it with the exact coding precision that matches this incredible clinical severity. So shifting gears to our master coder persona, how does this actually translate into our ICD-10-CM manual? The absolute crucial point here is your mnemonic anchor keyword, and that word is ascites. Ascites is that abnormal buildup of fluid in the abdomen because the liver is failing. If your provider documents alcoholic hepatitis but doesn't mention ascites, you're going to assign K70.10. But the second you scan that chart and spot the word ascites, boom, your code instantly changes to K70.11. The presence of that fluid drastically changes the patient's clinical picture, and pulling K70.11 ensures the record actually reflects that elevated risk. Oh, and before we leave the liver, we have to talk about the golden rule of coding any alcohol-induced condition. You literally cannot just code the physical manifestation. You must document the behavioral root cause alongside it. It is mandatory to pair these physical GI pathology codes with the primary underlying substance use disorder from the F10 series. So based on the notes, you'll pair your K code with F10.1 for alcohol abuse, F10.2 for dependence, or F10.9 for unspecified alcohol use. Doing this paints the complete, accurate picture of what's going on with the patient. All right, let's transition away from the liver and move down to section 2. We are looking at the pancreas now, specifically acute and chronic alcoholic pancreatitis. The clinical presentation mapping for this one is really fascinating. When a patient develops alcoholic pancreatitis, usually after years of heavy daily drinking, the presentation is just explosive. Reading the chart, you're going to see notes describing severe epigastric pain. That's that intense pain right in the upper middle of the abdomen that distinctly radiates straight to the patient's back. You'll also want to aggressively check those lab results. The hallmark indicators to scan for are heavily elevated levels of lipase or amylase. We're talking often greater than 3 times the normal limit. So let's break down how this pathophysiology actually builds, because once you understand the mechanism, the coding just makes total sense. Why does the pancreas hurt so much? Well, it's this terrifying process called autodigestion. Normally, your pancreas creates enzymes to digest food, right? And they safely activate later, once they reach the intestines. But excessive alcohol consumption causes a major glitch, premature activation. Those enzymes wake up while they are still trapped inside the pancreas.
So the pancreas literally begins to digest itself. It's intracellular enzyme autodigestion, and it triggers massive, severe inflammation, edema, and cellular injury.
Right, so how do we code a pancreas that's actively digesting itself? For acute alcohol-induced pancreatitis, your number one keyword to aggressively scan for is necrosis, which means dead tissue. If the notes show no necrosis or infection, you pull K8520. If the autodigestion is so bad that tissue has died, but thankfully it isn't infected, you upgrade to K8521. But what if that dead tissue becomes infected? That is a massive clinical emergency, and you absolutely must code K8522. This level of specificity completely changes the DRG and the expected care pathway. So whatever you do, do not miss the word necrosis.
But what happens when this isn't just one acute attack, but a long-term, progressive burn over years? Well, that leads us right to K86.0, alcohol-induced chronic pancreatitis. Unlike the reversible cellular injury we just talked about in acute cases, chronic pancreatitis involves permanent structural damage. We're talking fibrosis and atrophy. So in the chart, you won't just see pain. You'll see imaging that shows literal calcifications on the pancreas. You'll probably see steatorrhea, which is fatty stool because the pancreas just can't digest fats anymore. And in the late stages, you'll even see secondary diabetes mellitus because the insulin-producing cells are just gone. All of these chronic markers point you straight to K86.0.
Moving on to section 3, we're heading back up to the liver to discuss the absolutely devastating end-stage result of chronic alcohol abuse, cirrhosis of the liver.
Okay, let's look at the physical pathophysiology of cirrhosis. Picture a smooth, perfectly healthy liver. Now, compare that to a cirrhotic liver after years of alcohol toxicity. What's happened is that the healthy, functioning liver tissue has been permanently destroyed and replaced by useless, hard fibrotic parenchyma. Honestly, it kind of looks like a cobblestone street. And because this new tissue is basically just dense scar tissue, blood can't flow through it easily at all. Ultimately, the liver just stops performing its essential filtering and protein-building functions. To code this accurately, you really need to rely on this visual coding matrix. Everything hinges on whether the cirrhosis is compensated or decompensated. Compensated basically means the liver is heavily damaged, but, it's still scraping by. If it's alcoholic cirrhosis without ascites, that's K70.30. If ascites is present, you bump it to K70.31. Now, if the record documents cirrhosis without specifying if it's compensated or decompensated, you've got to use K74.60. But what if the liver completely fails to compensate? That's when we look at K74.61, decompensated cirrhosis. You'll know to pull this code when you see some truly horrific secondary complications in the chart, things like esophageal varices, which are swollen, bursting veins in the throat, or hepatic encephalopathy, where toxins literally reach the brain and cause severe confusion. Those secondary complications drive you straight to the decompensated codes. All right, let's step into our final section, section 4, alcoholic gastritis. We're moving right into the stomach to examine alcohol's direct caustic impact on the mucosal lining.
As our clinical pathologist persona would tell you, alcohol is essentially a solvent. When it's consumed chronically and in really high volumes, it acts as a direct, aggressive chemical irritant to the stomach. It severely inflames and chemically burns the protective mucosal lining. Over time, all this constant irritation wears down the mucosa, leading to super painful erosions. Basically, the stomach completely loses its natural defenses against its own acids.
And that brings us to our final, absolutely critical coding rule. For alcoholic gastritis, the master coder's eye needs to lock on to one very specific concept: active bleeding. If the chart just shows inflammation and erosion, you assign K29.20, alcoholic gastritis without bleeding. But if that erosion goes deep enough to strike a blood vessel, the patient will actively bleed into their own stomach. You need to be aggressively scanning for clinical terms like hematemesis, which means vomiting blood, or melena, which is a dark, tarry stool that indicates digested blood. If active bleeding related to this alcohol-induced injury is documented anywhere, you immediately upgrade that code to K29.21. So here is the question I really want to leave you with today. When you open up your very next patient chart tomorrow morning, are you going to be able to instantly connect the horrific clinical presentation of autodigestion or the physical presence of ascites directly to its exact ICD-10 code? Because when you truly understand the underlying pathology, you aren't just memorizing random numbers anymore. You're translating human anatomy directly into actionable healthcare data, and that is incredibly powerful. Thank you so much for joining me on this clinical journey today. Keep scanning those charts carefully, and as always, like, share, subscribe to Decode Healthcare with Harshal.